Okay, well, good morning, everyone. It's my extreme pleasure. I'm honored and humbled to be able to introduce today our visiting professor coming to us from all the way across the pond in London today. Professor Andrew John Timperley from the Exeter Hip Unit in Exeter is here to present today on his experience over the last portion of his career on the use of what has become and remains one of the most widely used hip implants in the entire world. And it's a hip implant that's been around for 50 years, believe it or not. The work of Professor Timperley has really revolutionized, I think, the way we think about hip arthroplasty here in the United States. Since the 1990s, the US has had a significant shift in the way that we performed arthroplasty towards cementless fixation, almost to a point that has been even described as an epidemic caused by our sort of reliance on cementless fixation at times. The multiple publications and ongoing dedication to the pursuit of excellence in the field of hip arthroplasty by Professor Timperley and his group has really set the bar for a shift back for us to reassess here in the United States how we perform hip arthroplasty. And I think what we're seeing now as a result of Professor Timperley's work is an increased utilization in cemented fixation. Today, Professor Timperley has two talks that he's going to give to us. The first hour, he's going to talk about the 50-year history of the Exeter hip and cemented fixation. In the second hour, he's going to give our residents and fellows and whoever is willing to stick around to listen a little bit more about the sort of technique behind cemented fixation and how they become so successful with the use of this implant. Professor Timperley has dedicated his life, as I mentioned, to the pursuit of excellence and outcomes. He continues to be heavily involved in research. As many of you may know, the customary way of addressing our surgeon colleagues across the pond in the UK is as a Mr. Professor Timperley has actually gone back in his mid-career and obtained his PhD at the esteemed Oxford University, and continues, as I mentioned, to dedicate himself in this field of education, research, and advancement of technologies. It's not just in cemented fixation, but also in surgical technique, including his interest in the spare technique, which is a surgical approach to the hip that spares the piriformis and only sacrifices the operator externus, as well as in the utilization of advanced technologies, including robotics in the form of the Mako robot for the use in outcome improvement in hip arthroplasty. So although he continues to identify the Exeter stem and cemented fixation as an area of excellence, that is not because it is an old technique that the UK has relied on forever. It's rather that it has excellent outcomes. And it's really exciting for me now to be able to turn over the microphone to Professor John Timperley. John, thanks so much for joining us.
Thank you very much, and thank you for your kind words. It's a great honor for me to be to address the University of Utah, and I'm very just sad I can't be there with you. I'd love to see your beautiful state. I'm just trying to share the screen here. Okay, can you see my screen? Yep, okay, lovely. So what I'd like to really is, as Chris has said, talk about what history has taught us over the last 50 years and really why cemented hips will be part of our future. Because actually this is a hip that's not only 50 years old, but it's continuing to grow on all continents. And I think that's largely because of the history of it and the fact that it has such good results. So these are my disclosures. I have been involved in the development of some of the implants and instruments. And my hospital does get an institutional contract for research. And really, it's a 50-year-old fairy tale. And it was a big date last November, because it was the anniversary of the first implant being put in by Robin Ling in November 1970. And really, it's been a fairy tale because so much has happened during that 50 years that has really guided us and on how to advance the technology and the techniques and get even better results. And even 5 years ago, I thought we did a pretty good job, but even in the last 2 or 3 years, I can tell you the techniques have improved so much that I think it evolves all the time. And it's still very exciting. And these are just some of the milestones from my institution. So on the left, you can see the implants that have developed in terms of offset, leg length, length of the stems. Yes, the impaction grafting technique brought about some other hardware in terms of meshes, and the cups have evolved somewhat. The techniques are listed in the middle column, and really Robin Ling was obsessed with cementing technique from a very, very early stage. In fact, it's one of the things that drove him to create a new implant was to improve fixation. And I'll say quite a lot about fixation in this presentation. Impaction grafting on both the femoral and acetabular side, custom-made devices for infection using the implant itself. And then what we do mostly for revision now is cement in cement. And I'll say a little bit more about that because that's one of the real reasons to use a cemented implant in young patients. Surgical techniques, tendon-sparing techniques, in conjunction with Mako robotic assistance, I think is what's made the huge difference in the last couple of years. And then because it was a collaboration between Robin Ling and Clive Lee, who was an engineer, there's been quite a lot of work done at the laboratories over the years. And the other obsession of Robin Ling was to gather data. And he has gathered data. We have data on all patients since 1970. And we don't discharge them, we continue to follow them up. We have an RSA unit. We started doing work with portable gait machines and activity monitoring, and actually have a non-arthroplasty hip register, which I started when I was British Hip Society president, which is now beginning to evolve. And we're currently getting we have some national funding for multi-center studies looking at the spare technique in hemiarthroplasty and in total hip arthroplasty. So these are the 3 reasons I think that the Exeter hip has survived the past 50 years. The heritage of it, the evolutionary innovation, and the results. And I'll just look at these in different sections. So if we look at heritage, this is Robin Ling, who died sadly 2 years ago, just as he had turned 90. And I think for many of us, he was the natural successor to Sir John Charnley. So you may know that John Charnley was the first one really to popularize hip replacement. And for many of us, Robin Ling took that understanding and knowledge and progressed it and was his natural successor. And I'll say a lot more about Robin. And he was very keen at clinical observation and working out what was happening in the patient and then proving it in the laboratory. And historically, of course, in our specialty, people have often started in the laboratory, gone to the patient and found actually it doesn't work. But he tried to explain in the laboratory what was observed in clinical practice. And he had enormous attention to detail. So he would never leave the operating table before he'd done the very best he could for patients. And he always said that a lot of what went on was serendipity, so that the happy progression by chance, but I think it was more due to the things above than any serendipity, although there clearly was a bit of that in the history, as I'll explain to you. And so here he was back in the late 1960s, looking at implants and developing techniques. And he was a very self-effacing man. And so most of the time, people with big egos push themselves to the front of their colleagues to show how important they are. But here he is at the back of his colleagues back in the 1970s. So he was very humble man, but made such a great contribution. And we had a celebration of his life in 2018, and people flew in from all over the world. It's Henrik Malkow, you may see at the front there, as one of those who came in, because I think it was recognized the contribution he had made. So if we go back to where it all started, he started developing it in the late 1960s, and he wanted an engineer to help. So he collaborated with Clive Lee at the School of Engineering in Exeter. And he wanted a new device because at that time, there were only a couple of devices available, one of which was the Charnley. But if you wanted to do the Charnley, you had to go to Wrightington to be trained, and you had to use a tray system and take off the greater trochanter. And he didn't want to do that, and he didn't want to use more than one assistant, and he wanted to improve fixation. So this was the original stem. As you'll see, it's completely without a collar, which was revolutionary in that day, rather broad proximally, stem distally, and it was tapered in two planes. So you can see how it's tapered from the frontal view. If you turned that stem through 90 degrees, it's also tapered in the other plane. And Robin was very aware, even at that time, that he wanted to expose as few patients as possible to danger. So he had an agreement with the London Splint Company, who made it at that time, that it would only be used in Exeter for the first 5 years to make sure that it wasn't a disaster. And the tapered stem, nothing was known about transmission of load or the material properties of acrylic bone cement at that time. And the tapered shape was merely designed to push the cement into the endosteal surface at the time of stem insertion. So it was more to gain fixation than for any other reason. And I think that's part of the serendipity. There was some preclinical testing, but as you can see, it was pretty basic. The implants that you see there are the ones that were available at the time, the McKee-Farrar from Norfolk and Norwich, and the Austin Moore and the Exeter had some sort of load deflection curve in between those. And so that was pretty much all that was done back in the late 1960s before it came onto the market. Very different now. And another part of the serendipity was that it had a polished surface. Indeed, any implant at that time had to have a polished surface because it was part of the British standard for any implant made of stainless steel. And it was made of EN58J. So there was no option, whether it was a plate for fixation or an implant, they had to be polished. And of course, the highly successful Charnley, first Charnley hip replacement also had a polished surface for the very same reason. And they observed things in the first cases that almost made him give up this implant because it was so revolutionary in design without a collar, that they did notice this incidence of subsidence of the stem within the cement mantle. So you can see, bear with me. So you can see quite clearly here that this stem has subsided between where it was up here against the cement mantle, quite a lot here. It's obviously 4 or 5 millimeters. They didn't all go that far, but those were the days of really basic cementing technique with no plug, no pressurization, and they did subside, but they had excellent clinical results. And initially, Robin thought that the cement mantle was fracturing, that this was the cause of the stem subsiding within the cement mantle. But in these cases, in the first 5 years, there was excellent preservation of bone at the top end of the femur in Gruen's zones 1 and 2. They didn't see radiolucent lines at the cement bone interface. And importantly, they didn't see any endosteal bone lysis. And so you can see in this case, this wasn't typical, but there's a punch-out fracture shown there. So the stem has moved slightly, there's been a punch-out fracture, but there's no reaction to that, even in the long term. And the bone is well preserved, so that by Wolff's law, it seemed that this implant was loading the bone in a way that was satisfactory for its preservation, and it didn't get lysis. But he had the opportunity to go into some of these hips because 1 or 2 of them fractured at the neck. So they failed for a reason other than failure of fixation. And it allowed him to look at the cement mantle. And in fact, he found that these mantles were not fractured. So these stems had managed to survive with subside within the cement mantle by a mechanism other than cement fracture. And this led Clive in the laboratory to do all the work that you now read in any orthopedic textbook on creep and stress relaxation of polymethyl methacrylate. So you can see in this jig on the left, there is a piece of polymethyl methacrylate, which is being loaded in 4-point bending by this mass underneath. And you can see the deflection of that piece of polymethyl methacrylate. And with the passage of time, that deflection, that deformity does not recover. It's not elastic, it's plastic. Something has happened to the mantle of cement, cold flow, which has allowed it to keep the shape that has been made by this rig. And he did this experiment on various bone cements. And the bottom line was that they all deflect. They all creep. And the amount of creep you get depends not only on the load, but also on the temperature. So it creeps much more at body temperature than at room temperature. And if it's in fat, it also creeps more. So these were all very important properties of acrylic bone cement. And really this can be seen in a way that's much more graphical by this experiment that Clive did. So he had a taper which was fully polished, as you can see here, and he cast around it a mantle of polymethyl methacrylate so that it was the same shape as the taper. And then once that had polymerized, he put it within a constraint into which these circumferential grooves had been made. And then he put it all in a saline bath at 37 degrees. He made sure that it wasn't end bearing so that the taper could subside within the cement mantle. and then he loaded it with a constant load on the taper, as you can see here. So this was the specimen before the compression test. The taper was put in the middle of that. It was put into this rig with the grooves in it. And that's what it looked like after it came out. So you can see that effectively this cement has flowed into these grooves. So the stem has subsided, but rather than fracture, the cement is actually deformed and flowed out into the grooves. And so really proving the concept that these stems can subside using the material properties of polymethyl methacrylate. And if you look in any orthopedic textbook on arthroplasty now, you will see some of the work of these two gentlemen there, looking at this creep, and also a phenomenon called stress relaxation, which is really the opposite of creep, where you get a reduction in the stress within polymethyl methacrylate with the passage of time. And really what happens is that there are secondary bonds between the long molecules of polymethyl methacrylate. And as these reptate, the material gets at a lower energy level. So the stress within the material can actually reduce with the passage of time. So I'll explain all this in how it works in a minute. This is how it's now recognized that the stem works. The stem moves within the cement mantle. So it is free to move between the stem and the cement. And as it does so, if you imagine taking a section at any level of the femur, you can see here the cross-section is the bone, the yellow is the acrylic bone cement, and the blue is the cross-sectional area of the stem. So as you apply load, the stem subsides a few microns, and as a result, the cross-sectional area increases. So something has to happen here. You've got a larger piece of metal at any section that you take within the femur. You get compression across the acrylic bone cement, and we know from the static properties of acrylic bone cement that it's strong in compression, it's relatively weak in tension and shear, but in compression, it's extremely strong. But you also get hoop tensile forces because you've got a bigger chunk of metal in that cross-sectional area. So during rest period, the stem does not back out, but the loads are reduced, and these hoop tensile strengths dissipate by stress relaxation. So the secondary bonds between the long chain molecules reptate. There is the tension dissipates somewhat with the passage of time, but the compression remains. And so there are really three consequences of the stem subsiding in this way. The first is that the cement loading is dominated by compression. And as I said, the stem is really strong in compression. The second is that these compressive stresses are transferred to bone. So you could argue that you're protecting the important biological interface, the cement-bone interface, by what is happening at the stem-cement interface, because you're compressing the cement against the host bone. And the third thing was really the torsional stability is also greatly enhanced as the stem subsides within the cement mantle. Now, if you look at the history over the 50 years, the stem, as I mentioned, was used in Exeter between 1970 and 75. There was a change in 1976 in that this requirement for the stem to be polished disappeared. And it was cheaper for the manufacturers to make a matte surfaced implant because what they do is they shot blast it instead of hand polish it. They shot past it with ceramic particles. It gets a roughish finish. And nobody thought at that time this would make any difference at all, but it had a profound difference, as I'll explain to you. And it took 10 years, really, for Robin and Clive to recognize that it was the surface finish that had made this difference. And it went back to being polished and monolithic in 1986, and then its present form a year later from 1988. So there's been no change over that whole period, over the 50 years. In geometric terms, that has remained the same. It's collarless, it's a double wedge, and it has a tapered geometry. The only difference since 1988 is that the spigot has changed a little bit to allow ceramic heads on top, but the bit and the neck is slightly thinner, but the bit that is shown to the acrylic bone cement is exactly the same and has not changed since 1988. But there was a difference between the results of the first polished Exeter hip put in over the first 5 years and the subsequent matte Exeter hips. So this difference is entirely caused by this difference in the surface finish of the implant. it wasn't a catastrophe, the mat Exeter, but they failed at about 1% a year. And surgeons at that time had not ever seen these appearances before. In fact, when they started seeing endosteal bone lysis, they weren't sure what it was. They were biopsied. They thought it might be infection. But this led to all this work that Clive and Robin did in the laboratory to explain it, and then subsequently for more work to explain why it's so important that it has a polished stem. And here you can see an Exeter mat stem, and you can see very clearly that that it's been explanted, that there is a polished area medially, and that the mat surface remains laterally, and that if you take a TallySurf machine and measure the surface roughness, you can see it's twice as rough. Well, it's retained its roughness on the lateral portion, but it's been polished on the medial portion. And this polishing was always anterolateral and posteromedial and reflects the outer plane forces. So as you stand from the seated position, there's obviously a backward directed vector of force, and the stem can rotate within the cement mantle and polish off the surface. And this was what was seen on some of these explanted implants. And of course, this gives you the capacity for the stem, if it moves within the cement, to create debris. And if you can imagine the interdigitation of cement against the surface of the stem, if it's polished, as you can see here, this very smooth polished surface here, if that cement moves on that polished surface, it doesn't make any difference at all. But if there's movement between the stem and the cement on an implant that has a surface finish like this, then you're going to create debris. You're going to create debris of the polymethyl methacrylate and indeed of the metal. And it's the metal that was abraded, as you can see by that polishing. And these matte surfaced implants, they weren't rough to touch. I mean, they felt completely smooth, but they were 100 times rougher if you actually measured the surface roughness. And Jonathan Howell, one of my colleagues in Exeter, did his thesis looking at micromotion and its clinical relevance. And again, you can see on this particular stem, this polishing that carries out. And Jonathan looked at areas of this was a Charnley stem in which was unworn. And you can see very clearly, if you look at this surface, it has like mountains and troughs on the surface finish. If you looked at an area that was partially worn, you can see that the tips of those mountains have been sheared off. So that material has been lost into the interface. And then if you look at a highly polished area, you can see that the mountains and the hills now have effectively gone, and you end up with only the valleys left. So that material has been lost to the interface. And if you look at this with a scanning EM, this is an area that is not damaged in any way. That's what the surface looks like with a scanning EM. If you lower the angle of incidence, increase the magnification a bit, this is an area that is partially worn. And you can see how the tips of those asperities have been amputated. And if you look at a highly worn portion, you can see that they've all gone. And these areas of white that you can see here are actually alumina particles. So that's the way that these matte surfaced implants were made. They were bombarded with alumina particles to make the surface rough. And some of them became embedded in the surface of the implant. And so as this abrasion and polishing went on, not only did you get polymethyl methacrylate debris and metal debris, but you also started releasing alumina from the surface. And of course, that's one of the hardest materials known to man. And really, this has led to there being a spectrum of theories of stem fixation. And really, there's what's caused the shape closed or composite beam end of the spectrum, and the force closed or taper slip stem, of which the Exeter is the prime example. And really, we have here Bill Harris and Robin Ling, and they both championed implants at opposite ends of this spectrum of how the cemented implant should be fixed. So I've explained to you how Robin Ling explained that the force closed or taper slip design stem works. Bill Harris believed that the way cemented stems failed was failure of the stem cement interface, and then fracture of the cement, and then the whole thing became loose. So his whole philosophy was to create a composite beam. In other words, to try and lock up all of the interfaces so that there was no movement between the stem and the cement, And then, of course, the hope that there was no movement between the cement and the bone. And to do that, one of the ways he did it was to have a collar on it. Another way was to pre-coat it. So he worked out that if the failure mechanism is going to start between the stem and the cement, then you better fix the cement on as best you can. And so he wanted to, he did that in the manufacturing process. Now, there are one or two composite beam stems that do work, but the pre-coat was not one of them. And if you do try and get those to work, it's very difficult to get them to work, and the results are not generally as good. Whereas the force closed or taper slip design is much more forgiving for the surgeon to get a decent result. And all of the implant manufacturers now have a taper slip design of cemented stem, I think, for that reason. So if we look at these again, I've explained to you that the taper slip stem can move within the cement mantle because it's polished, it doesn't create debris, protects the bone cement interface. With a composite beam, the beam is everything. So you're locking everything together. You're bonding the stem to the cement, you're bonding the cement to the bone, and then you're trying to hope that that lasts over many decades. And of course, that's very difficult to do because you have something of very high modulus of elasticity, a large lump of metal down there. You've got polymethyl methacrylate, which is very low, and then you've got bone, which is somewhere in between. So you've got materials and shapes of different modulus of elasticity, and then you're hoping to lock them all together and that they function as one. And what we discovered, and many implants have discovered, is that is really very difficult to do. The other thing that has become obvious over the 50 years is how a stem of this type transmits load to the femur. And I'd like you just to think for a minute about how a normal, how load has transmitted to a normal femur. That as the vector of force comes through the femoral head, you have these trabecular arches. This one's called the principal compressive group, as you know here. And there's another one which has always been called a tensile group, going from the inferior part of the head over here. The important thing to notice here, not only is these trabecular arches, but look at the thickness of the cortices. So in the neck, the cortex is extremely thin, both superiorly and inferiorly. And it only starts beefing up in the calcar area as these trabecular arches, trabecular bone is inserted from the endosteal surface. And as the bone is inserted, it thickens up and it becomes a normal medial cortex down here. And it's true on the lateral side. So that if you see this trabecular arch, the so-called tensile trabecular arch, the bone is very thin here, but it starts beefing up as this trabecular bone is inserted from the inside. And then if you look at a normal x-ray, you'll find that the lateral cortex and the medial cortex are the same thickness. So by Wolff's law, they must be both important in transmitting load as well. And there is the so-called normal trabecular arch. This is the trabecular arch, which is said to be in tension. But if you look in the textbooks that talk about this arch being in tension, they're really ignoring the effect of the vastogluteal sling, and there's and the resultant vector of force that comes from that sling of muscle. So you've got the quadriceps muscle. It's a little bit like the knee with the patella. That you've got the quadriceps muscle, the patella tendon, and the resultant force. And this is a book on the hip by a surgeon from London called Sinclair Strange, and he likened it to this chap hanging on to a winch here. And his legs obviously are this so-called tensile trabecular arch. And he says, very difficult, not recommended, but who would contend that the superior trabecular arch is not in compression? So I'd put it to you that both of these arches are in compression, and that the way that the normal femur transmits load to the distal femur is it's a damped load, and the damping is carried out by the effect of these trabecular arches, so that what the femur, the cortices experience is a damped load. And of course, the most unphysiological thing you could do is then put down a large lump of metal down the femur and expect it to transmit load in the same way. Well, we have an advantage with acrylic bone cement because, of course, it's a very low modulus material. And so nothing will transmit loads in a physiological way, but it's our belief that actually that loads are more damped because of this material that is between the very rigid metal and the host bone. And with this type of stem, the lateral side is just as important as the medial side as far as load transmission is concerned. And you will see, and that's the reason I think that if you look in the long term at the x-rays, the bone in the calcar area is maintained despite, or in fact, you could argue because there is no collar. A collar, if you just imagine putting a collar, a lump of metal on the calcar, there's no way that's a physiological load. And one of the reasons Robin took the collar off, because he recognized that even if you could get collar-calcar contact at the time of surgery, it never stayed there. There was either lysis or there was stress shielding beneath it. So that was the reason there was no collar. He just didn't think it conferred any advantage at all. But the belief is that this stem can transmit loads in the way I've described to the proximal femur as much as the distal femur. And in fact, Clive did some work and showed that 60% of the load of this type of implant is shed proximally rather than distally. And the proof of the pudding really is in the x-rays. So this is the preoperative x-ray of a lady in her 30s who had two previous cemented stems in London, and she was referred down for this technique of impaction grafting. Now, for those of you who don't know, impaction grafting is a technique where you remove all this material, you mince up femoral heads, allograft bone, and then you pack down these morsels of allograft bone down into the canal, leaving a space in the middle that you can then re-cement into a bed of bone graft. So that was the preoperative film, and this is the immediate post-operative film 2 days later. So thing to note here is that there is no bone here in the calcar area, and down the lateral side here in zone 2 and 3, it's extremely thin. And there is no trabecular bone here, and there's very little trabecular bone on the lateral side. And in the post-operative films, you can see that there is an amorphous appearance of the allograft bone. You can see very clearly the cement mantle, and then the Exeter stem has been put in, and they are now put in with a void on the tip so that the stem can subside a millimeter within it, leading to this compression. So then you can see at 8 years how that cortex distally has repaired in zone 3. And if you look at the cortex in the calcar area and the trabecular bone, you can see how this bone has remodeled. And now you have the trabeculae streaming out of the cement mantle being inserted into the endosteal surface of the femur. Please note that the stem has subsided 3 or 4 millimeters within the cement mantle, but the femur has basically reconstituted as a result of the allograft bone and the way that the stem is loading the femur. And just to show you the postoperative film again, with a 2-year film in a bit more definition, you can see again how this appearance has changed between the post-op appearance and later on. So really, rather than being what some people call concrete, the acrylic bone cement has material properties, both short-term and long-term, which are hugely beneficial in arthroplasty. And it's an organic material, and it's what contact lenses are made out of, fiber optic cables. So it's a state-of-the-art material, and it confers huge benefit, as I mentioned, in arthroplasty. And some of those benefits I will go on to discuss with you. But really, to understand the cemented hip replacement, we can't lump them all into one group and say cemented hip replacements do or don't work. I mean, there are hundreds and hundreds of different types and shapes. Some have collars, some are matte surfaced. They work in different ways, some don't work at all. And I think one of the reasons the US fell out of love or never got into love with the cement is because the FDA didn't allow its use for a decade. And when it was allowed and was used by surgeons in the US, it was used with implants that didn't use the material properties in the optimal way, by this taper slip principle. The other thing that Robin was really obsessed about, as I mentioned to you, was improving surgical technique. So one of the original stems is shown on the left, finger packing, no plug. They did pretty well, but they did extremely well, but they did subside a few millimeters, whereas today, with modern contemporary cementing, the average substance is 1.2 millimeters. So it's clinically irrelevant, but you see it in almost all cases. And from a very early point in Exeter, Robin was working on acetabular pressurizing techniques. So this pressurizer was first used in 1970. It was a balloon on the end of a stick, effectively, with a reservoir of fluid in the handle. And you inflate this inside the mouth of the acetabulum and then push on it with all your might for a few minutes and then put the cup in. And then the cement gun came a few years later. And the lavage system was started in 1970. So it became recognized that you need to clean the interstices of the bone with a pressurized system in order to allow the acrylic bone cement in. And then using that with ways of occluding the top end of the femur with a femoral seal, as you can see here, and then forcing the bone cement into the endosteal surface of the femur. And we have Per-Ingvar Brännmark to thank for our understanding of osseo integration. And he was the man who first coined the term osseo integration. And the implant company has gone about biologic fixation. But what they're talking about is what Brännmark described. It is direct contact between a man-made implant and host and bone without an intervening cellular layer. And you can achieve that with acrylic bone cement just as you can achieve it with titanium. And these are some papers from Lars Linde, who looked at it, and also Moberg, looking at osseo integration and whether it can be achieved. And there was a pathologist called Archie Malcolm who was sent to retrieve 70 of John Charnley's successful hips from patients after they'd died. And he cut them up, and he found that throughout most of their entire length, there was direct contact between cement and living bone. So just as some metals can become osseo integrated, so acrylic bone cement can be osseo integrated. But it relies upon getting mechanical interlock. And then because of the stability achieved by that mechanical interlock, you can then subsequently get osseo integration. And the techniques have been described by which you dissolve the bone cement and then you find that it is osseo integrated. And this is a really good paper for any resident to read. It was published in Clinical Orthopedics in 1986. But it's pivotal, really, I think, to our understanding of what you're trying to achieve when you fix any implant to the bony skeleton. And what Robin described was that there is a spectrum of junctional tissue at the interface between the implant and the bone. And the nature of that junctional tissue depends upon the mechanical environment. So what you're trying to achieve is osseo integration, so that you can, so that the interface can tolerate high loads and has strong interlock. If you do a poor job and there's very poor mechanical interlock, then these things cut out a very low applied loads. And depending on the mechanical environment in between, you end up with thicker and thicker soft layers until the cutout, or a single or a few cells in there. And really, Robin made himself quite unpopular at the time that he wrote this paper, because he put the onus on the surgeon. He was one of the first to say, actually, it's not the patient rejecting their implant or necessarily the implant fault. It's actually the surgeon who creates the mechanical environment, and that cement is not a glue, that it is a cement, that it has to interdigitate and take a cast of the surface with which it comes into contact. And then if you have stability, you can get osseo integration. So if we look at the way innovation is carried on, I'll just show you that slide again. One of the other things that the evolution that's carried on was the understanding of how we accurately want to recreate the biomechanics of the hip, and how that is actually much, much easier to do with a cemented stem than an uncemented stem. So what you're trying to do is create the offset of the stem, the distance between the center of rotation of the head and the mid shaft of the femur. We want a stem of a size that is enough that they won't break and is appropriate for the patient. We want to get the correct leg length. And of course, we want to get the correct anti-version for that patient, because there is a range of version, which I'll talk about. And the beauty of using cement is you can basically put the stem wherever you want. So all of those parameters, offset, leg length, stem size, and version, are independently variable if you use a stem of this type. And it is absolutely not true of an uncemented implant, where basically the stem size very often dictates the offset, although you can get high and low neck lengths. But then if you rely on the fine tuning with putting a plus or minus head on, then you increase both the offset and the leg length. So they're not independently variable. And the beauty of this type of system is that you decide on the offset, and then the leg length is how far you put it in, and you can dial in as much version as you want. And this is important because it does have an effect on gait. And as we're becoming more sophisticated looking at our outcome measures, you can see that there is an effect on gait defined by the surgical approach, by leg length inequality, or by getting the femoral offset incorrect. So what you really want is a system that allows you to restore the offset, get the leg lengths right, and then adjust for the version that patient needs or wants. So for those who are not quite certain, that's what's meant by offset. It's the distance between the center of rotation of the femoral head and the missed shaft of the femur. And if you look at the normal population, there's a bell-shaped distribution. So the average offset of the population is just over 40, but it can go up to over 60 and down to less than 30. So you want a system that you can get that offset with a stem of an appropriate size. And the Exeter system does do that. So we have offsets down to 30, all the way up to 56. And you can imagine that if you put a minus head on a 30 and a plus head on a 56, you've pretty much covered that whole bell-shaped distribution of what you're trying to achieve when you recreate patients' anatomy. And just to show you the effect of this is to look at, just to show you a few templates. So if you look at these dots on here, we've got the femur down the shaft of the femur in every case. And these are where the center of rotation would be with a 30 offset stem up to a 50 offset stem. So if you use a stem of a different offset, you can get that range of offsets. If you used a minus head, then of course you get those dots. If you sink the stem in 4 millimeters or more, you can have this cloud of choice of where the center of rotation goes. Of course, you could put a plus head on, and you can do all of this in 3 dimensions. So you choose the offset, you put it in terms of where, how far down you want the canal to go, and then you can dial in the version that you want. So you can put the center of rotation in an infinite number of places. And just to show that a little more, if you just imagine you want to keep all these tendons and muscles at the correct length, that's the center of rotation that you want. And you want to keep the femur in the same position in relation to that center of rotation to keep the muscles and the tendons at the correct length. So you can see in this particular case, a 37.5 offset stem is the right leg length, but it's not the right offset. A 44 is not quite enough. A 50 is too much. And so you could compromise. You could either put a 44 on and put a +4 head on, and then sink it in a little bit more. Then you've absolutely got the center of rotation in the correct place. Or you could do it the other way around and put a minus on the other. But what the point it's making is you can get the center of rotation exactly wherever you want it in all planes. And this was a paper written by one of our fellows, Graham Holt, who looked at our technique of measuring the distance between the tip of the trochanter and the shoulder of the implant at trial reduction after templating, and then using that to get the leg length right and showing the smallest leg length discrepancy in the literature. So you can use this implant whether you have a valgus hip. Here you can see the center of rotation is very long in comparison with the hip, and you would need to leave it out. This is abnormally long, but you can see the leg lengths are correct, and the correct center of rotation has been achieved. Or if it's varus, you sink the stem in a little bit more, and that would be a bigger difference. And then the other thing you want to create, of course, is femoral version. So we know that there is a range of femoral version. If you look at the transepicondylar axis here and look at this one slightly retroverted, this one's extremely antiverted, the one on the right. And Fabio Catani is a surgeon in Bologna in Italy, and he measured this on 360 patients and described as being pathological in over half of them, and that a lot of them were retroverted. So if you look at the normals, look at how many of these are retroverted compared with what you expect. But of course, if you use a cemented implant where you're putting an implant into a viscous liquid, you have complete freedom of movement to put it wherever you want. And if we look at our Mako cases in Exeter, we measured the native version, and you can see there's a great range in the slide on the left of the first 50. The average is 6.6, and we increased the version in almost all cases. But you can decide where to put it, and you can put it exactly where you want to. And I think one of the areas of research that's going to be in the future is combining the version of the stem and the and the socket in different patients with different geometries and with different spino-pelvic problems. And Ranawat really looked at this idea of a combined version. So trying to get the version of the anteversion of the acetabular component, the femoral component, and describing it to be somewhere between 20 and 45 degrees. And if you looked at that on the Mako cases we did, and looked at the combined version, they're pretty much all within that box of optimal version. So it allows you really to do what you want to do. So this is a slide of one of my colleagues, Matthew Hubble, who says it's love from Exeter, length, offset, and version easily, really with one stem type. And then the final bit really is about data collection and results. And as I mentioned to you, data has been collected in Exeter since 1970, and it's allowed us to do lots of comparisons. And if you look at the results of that first polished stem inserted between 1970 and 75, it's the survivorship of the red line here. So at 33 years, the survivorship of that stem with primitive, I remind you, with primitive cementing technique was just short of 94%. And with decent cementing technique, when we looked at the Exeter universal stems between 1988 and 1990, there was one patient with Morquay's disease who failed, but the survivorship was 99.2% at 24 years. So these stems simply don't come loose. I mean, it's so rare to see a loose, polished, collarless, tapered stem. And of course, we have registers all around the world showing the same thing. So the UK one is the world's biggest. It's got about 3 million implants on. We've got about 1.5 million stems, I think. And the Exeter hip is the market leader in that by a country mile. If you look at the tendency, it was always said around the world that people were going uncemented. Well, we're going the other way. So if you look at the uncemented implants, they have been declining since about 2010, 2011. The hybrids have been growing. Fully cemented has been declining a bit. But if you increase, of course, the hybrids and the cemented, all cementeds all have cemented stems. That about 60% of all implants inserted in the UK are cemented femoral components, and the majority of those are Exeters because of the results. And we have a panel in the United Kingdom called ODEP, the Orthopedic Data Evaluation Panel, where they look at these implants, they look at the world literature and the registries and give a category for how proven they are. And at the moment, the highest you can get is 10A star, so a very low revision rate, 10 years, and all of the implants that we use are of 10A star. That's less than 5% revision rate at 5 years, and I think they're going to extend this to 15. But these are the results from the last registry. And if we look at 13 years of, this is the Exeter stem with various cemented sockets, you can see about between 2.5% and 3% revision at 13 years, failure at 13 years, and the hybrids just a fraction more, so about 3% at 13 years failure rates. So these all qualify for an ODEP 15A star rating. And I'll show you, this is the results from my institution. So just so you can get your head around this, this is called a flow chart. And on this diagram, this line here, basically the x-axis is the number of operations done at an institution. The y-axis is the number of revisions you would expect for the number of implants that have been done. And this is the average revision rate over the whole country. So each of these dots is a hospital or a group of hospitals in the United Kingdom. So the volume of surgery is given on this axis and their failure rate on the y-axis. And so if you're out here, you're plumb average for the number of implants you do. If you're up here, this is 2 standard deviations, the blue line. This is 3 standard deviations to the bad. So these hospitals up here have a really high failure rate, and I can absolutely guarantee they are metal on metal places that have used metal on metal. But I'm pleased to show you that the Royal Denman and Exeter Hospital is 3 standard deviations to the good. So this is operations within the last 5 years. And this is over the whole lifetime of the National Joint Registry that we're an outlier to the good. So that 3 standard deviation means that you're in the top 0.2%. And I just remind you that we use, it's the only stem on our shelf. It's used in all patients, all pathologies, all ages, and any anatomy. And the other graph I'd just like to show you is this one, which is the other way around. This is looking at the improvement in Oxford hip score. And again, each one of these is an institution, but here you want to be above the 3 standard deviation line, because that's the improvement that you can get. And you can see that we're actually an outlier to the good, that we have a greater improvement than would be expected. Again, used in everyone. So one of our fellows, Jonathan Evans, wanted to know, is this an implant thing, or is it that we just do the operation better? And of course, we were all hoping that he would show that we were better surgeons, but no, he didn't show that. What he did was take the data from our institution and compare it with the whole National Joint Registry. And he makes the point that if you look over the whole NJR, there are 3 hospitals which have better expected revision rates than all the others. And he wanted to work out, was this a patient effect? Was it a center effect in terms of the staff, the skill, or the system, or was it an implant factor? And so we had just over 6,000 implants at our institution, which he called the Exemplar Center. And in the rest of the UK, there were about 230,000 stems that he compared them with. And our results were better. So if you look at the revision rates at our center compared with the rest of the United Kingdom, they were doing better. But then what he worked out, we only use 1 stem. It's the only stem we use. And we've only, during the entire lifetime of the NJR, used, I think, 4 or 5 different acetabular components. And if you restricted the results from the whole National Joint Registry to the cases that had used the implants that we used in Exeter, then the curves overlapped and there was no statistical significant difference. So are the results generalizable? The answer is yes, if we restrict to the same implants. And is it a center effect or an implant effect? It's an implant effect. And he went on then in another paper that has been published, you can look to predict, using these data, the 30-year results of hip replacements on the NJR, looking at all construct failure with the predictive modeling using flexible parametric survival analysis. And whereas if you look in the literature at a meta-analysis of the sort of revision rate you would expect from the literature, it's about 42%. But the predicted results, if you use the Exeter stem and cup, is 5.1% 25-year cumulative revision rate. I mean, you can imagine the money that would be saved if only successful implants were used by all surgeons. And the very final bit of information I'd like to just give you is the final advantage of using these sorts of stem in the young is cement-in-cement revision. It's practically the only revision we now do in the femur. And it exploits the fact that these stems are effectively modular between the stem and the cement, and that the cement is usually Osseo integrated. So we do this for any indication that you need to get to the acetabulum for, or if there's any component malposition or reorientation required. So here's an 80-year-old female, 22 years after a fully cemented hip replacement. It was a matte surfaced Exeter, which has done okay. It was dislocating, and the dislocation was due to polywear at the back that you can't see. It's slightly out of plane. So what was done here, you just clear the shoulder of cement, knock the implant out of the cement mantle. So you can see the cement mantle retains in, it stays in there. Do a trial reduction, get the leg length offset version correct again. And then you basically just put another mix of cement inside the existing cement mantle and put a stem to the correct level with the correct antiversion to get the leg length right and the offset right. And it makes it a very, very easy revision. And there are now stems made that you can, are slightly shorter so that you can do this very easily. And the future, and if you want the present and future, well, the future, please stay for the next hour when I'll be looking more at the spare technique and the robotic assistance. Just to give you a little, wet your whistle a little bit, the spare technique is where you're preserving these external rotators. So basically, this is a right hip this is the interval that you would go in and cut everything to the right of that with a routine posterior, with the piriformis sparing you there, with the spare technique you go in here. And that really has become the standard of care in my practice. If I could just show you what can be achieved now using the spare technique, and if you get the biomechanics right, I'll just play you this. If I have time, Chris? I think you've probably seen enough, but that was her preoperative X-ray, and that's her post-operative X-ray. And I honestly think if we only had uncemented implants and somebody came up with polymethyl methacrylate, they'd get the Nobel Prize. This is the team in Exeter, and anyone would be very welcome to come and visit us in Exeter at any time. Thank you very much for your attention.
Amazing. Thank you so much for that wonderful presentation on the history. I think to the department, just these are the things that get me really excited. It's the science, it's the history, it's how we got to where we are today. And to see something that they came upon that has lasted and proven the test of time is truly impressive. Just before any questions from us, how about to the rest of the department? Does anybody have any questions for Professor Timperley?
I don't have a question, but I think it's fair to say that industry has driven a lot of the enthusiasm for continuous change over the past 4 decades. I'm happy to see this. I actually only know how to do cemented total hips. I would like to ask, though, if you could tell us a little about the acetabular side. Do you, at your center, do it looks like you do uncemented acetabulums and cups? I mean, and when would you pick that versus a cemented acetabulum?
Yeah, that's a good question. I mean, I historically was always a fully cementer. So if we published our results of cemented cups, and basically, if you look in the literature and our results now, the new generation of uncemented cups with new poly and cemented cups seem to be about equivalent at 15 years. So I think you can justify either. There is a group that definitely do better with cement, and that would be fractured neck of femurs in the elderly, do better with cemented cups than uncemented. But in all other groups, if you look in the registers, they seem pretty equivalent if you do a cemented cup well. And by preference, I would probably use a cemented cup for various reasons. But the truth is I use the Mako robot in almost all cases now. And I've become happy enough with the results of uncemented cups with new poly that I'm pretty much accepting that group of patients, very elderly. I'm happy to use an uncemented cup. But the robot, I think, is a big advance, especially if you're using new tendon sparing techniques.
How much does the type of polymethyl methacrylate matter? How much does the cement mantle matter? And how much does the distal pocket that's created by the centralizing plug matter? If you don't have a centralizer, or you do, and what is the distance that should be?
Okay, good questions. I mean, in terms of the different types of cement, I don't really think it matters which one you use. They all creep in the same way. The handling characteristics are different. So I actually use Palacos personally. Most of my colleagues use Simplex. It's just that you mix it for a different time, you insert it at a different time, you pressurize it for a different time. We'll talk about it in a minute, and then you introduce the stem at a different time, but they all work well. The ones that didn't do well were the butyl methacrylates, which are no longer available. Bone Lock, for instance, didn't do well. And some of the low LV ones are quite difficult to handle, and you compromise things a bit. In terms of the centralizer, I mean, I think it's relatively important to put it on. Sometimes in revisions, you compromise and don't if it's going to cause you problems. But you want the stem to subside a millimeter for the reasons that I've described. So we do put it on. And if it's a narrow canal, it actually has no wings. So it's not a centralizer at all. It's really a subsidizer. And the third question was?
Cement mantle. So maybe this also gets to another question. We've had some interest in the French paradox of cementation. Line to line cementation, so to speak. But how do you choose the size, and how much of a cement mantle is important, and what do you think of the French paradox?
Well, the French paradox, of course, is the French put the largest lump of metal they can down, but they get away with it, I think, because it's polished. And the most important feature of any of these stems is if it's polished, it gets you, that's the most important feature, I suspect. And if it's matte and it has an incomplete mantle, then the debris gets to the interface. So even with a polished stem, we like to have a complete mantle of cement. I'd prefer it to be a few mils thick because of the material properties that have been described, but I don't think it matters so much, but it must be polished, a complete mantle if you can. And and the stem size that's appropriate to the patient, because of course they're putting this stem through, a few million cycles a year, and over many, many years, you could get a fracture if you put something much too small for that size of patient. So reasonable stem size, decent cement mantle, but complete mantle of cement.
Excellent. We're at 8:02. We're going to continue on to the second hour, and I invite everybody in the department to continue. Before we sign off at the grand round session, though, is anybody else in the department that needs to leave have a question to ask of Professor Timperley?
No, but we'd like to have you out and show you Utah. So once COVID's over, you have an open invitation.
That's wonderful.
Yeah.
It sounds like you have a fantastic facility there, and I know Utah to be really beautiful, so I'd love to come.
Great.
All right, so thank you all. If you're going to stay on, are we going to stay on this call, Morgan, Andy? Think so?
Yeah, we'll just stay on this link.
Okay. Some of the fellows are asking, can we continue to record the second hour?
Yeah, I'm planning to.
Great. Awesome.